Critical Care Obstetrics podcast. I'm Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics. And I'm here again with my partners, Suzanne McMurtry-Baird, our Nursing Director, and Julie Arafay, our Simulation Director. So last time we had we really enjoyed the podcast on really can-do culture in healthcare and the impact it has on patient safety and risk and those kind of things. And we wanted to continue the conversation. It was just too much to talk about, and it was a bigger topic than we really anticipated. And so we want to continue that conversation about how this team culture of just make it work, can do, we call it the can do culture, the can do attitude, and how that can negatively impact your unit. I think all of us understand the positive. Like, there's nothing like a team that just makes it get done. And there are wonderful things in that. Great, morale boost. It's good for staff retention and all that other kind of stuff until it's not.
It feels good, It feels good, like we made it work,
It's a real team building feeling.
Yeah, it's
when
it
goes well.
Yes. But there's a downside to it, and I don't think we talk about it enough. So before we dive in, we want to remind you that we have other platforms. We'd love for you to find us in other ways. You can watch us on YouTube. Don't forget about the Critical Care Obstetrics Academy. That's online at clinicalconceptsinob.com, where you have a huge library of online courses that'll help you build confidence and your skills in managing high-risk and critically ill obstetric patients. We're on Patreon. If you like listening to us, we've got more stuff, more educational stuff, more one-on-one involvement, live sessions, patreon.com/CCOB, exclusive stuff that nobody else gets over on Patreon, and then on all of our social media. But let's move on to the podcast.
Yeah. I want to add one thing about our course.
Mm-hmm.
Recently I've seen a lot of social media posts about nurses taking our course for the OB emergencies certification, and how that helped them, how our podcast has helped them to really critically think through a lot of the certification questions and issues that are on that. So that is a resource for you if you're thinking about doing the OB emergencies. But also, I think a lot of nurses are using it for foundational knowledge, and physicians too, because our foundations course is really for everybody. It's not just about high risk or critical care. It's about the physiologic changes in pregnancy and things like that we need to know. Even if we have a patient that is doing a water birth, we still need to know the physiologic changes of pregnancy.
Yeah, absolutely.
So, yeah, I just want
you won't recognize if a patient's deteriorating if you don't recognize when they're not deteriorating.
Exactly.
Like what's normal and what's not.
Yeah.
So last time we focused a lot on risk and safety and, how important it is to understand what you do, what you don't do, staffing concerns, all of that kind of thing, that we just somehow managed to figure it out. In this podcast, I think we decided we want to focus on and continue the conversation and talk about workarounds, extra responsibilities, just taking on extra duties, and then finish or include talking about how all this impacts the team negatively and the individual negatively, like burnout and staff retention and turnover and all that kind of stuff. Even though the intention starts out good, it can end up really having a negative impact overall. So some workarounds. You guys want to give an example of a workaround?
I use this workaround all the time. When I was a simulation specialist, and this work is fairly well known, it was really nice because where I worked, it wasn't mine, it was where I worked, was right across the hall from patient safety and just down the hall from nursing education for the hospital. And if there was a big problem anywhere, like we would just organically talk to each other and say, there were direct lines of communication as well, but I was over talking with the head of patient safety and talking about the fact, the nurses are complaining about this medication dispensing device and they can't get their medications. And the workaround was to just go into that device, pull everything you need, and put it in your pocket. And I mean, she blanched. She's like, "Oh my God, you can't do that." And I'm like, "Well, you have to do it if you don't have what you need, and it takes you so long to get what you need, and your patient is hemorrhaging." I mean, an OB hemorrhage that's going full bore, maybe 750 milliliters a minute, is frightening. And to not have what you need, she's like, "Yeah, I understand that." And that's a workaround. And that whole problem was resolved through simulation, because what do? We video recorded the nurses getting the medication out of this non-functioning, but functioned some of the time, and usually that was when the people were there to fix it, this non-functioning machine. And we actually timed how long it took the nurses, and then showed that to the people who needed to fix the machine. Machine was replaced. It was defective. And the nurses had just been working with it and working with it and working with it. And this stupid defective machine. And it changed the whole practice on the unit. So it's these workarounds that you don't even realize, the consequences of that.
Got another example. One facility that we evaluated one time, and we've done many, many facilities, and frankly, every place we go, we find a workaround, if not many workarounds, because it's just part of what we do as healthcare providers, because the system isn't built to work for us, quite frankly. And many times it feels like it's working against us, like what Julie was saying. But here's an example of, this is not an equipment problem. This is a practice problem. So we learned that the nurses on labor and delivery were carrying vials of TURB or preloaded syringes of TURB in their pockets. More than one. Not just more than one nurse, but more than one preloaded syringe. And like ready to dose TURB immediately. And we're like, well, what? We weren't just like, you can't do that. The question was, because you can't do that. The question was, why are we doing this? What is happening that has created this unsafe practice? And we learned that their induction processes involved excessive doses of medications that created excessive contractions, that created fetal heart rate changes that necessitated frequent use of terbutaline to rescue the situation. And that's a workaround. That is an unsafe practice, but you don't fix it by slapping the nurse's hands and saying, don't carry TURB in your pocket. You fix it by going back and saying, we need to address the induction practices. And we did.
Yeah,
and
I remember
it
that
solves
place.
the problem. Yeah.
Mm-hmm.
Great intentions.
Great intentions. But I remember that. And we were a little shocked when we looked at their Pitocin protocol and their physician orders, and the misoprostol dosing was way too high, and they knew it, but they didn't have a process in place though to address that, and especially an interprofessional process in place. And they said to us, well, we kept telling our nursing manager or nursing leader about it, and they didn't do anything about it. Well, if that happens and nurses are constantly going to you with the same thing and you don't do anything about it, guess what happens next? They stop coming to you about that issue. They shut down their concern and they do a workaround to deal with it because you haven't done your job as a leader to address it. And that's just normal human behavior.
That creep, I mean, that's a great example of how it creeps. Like it's a single deviation or workaround creates creep in process changes everywhere. So, we see it with normalizing the abnormal or normalization of deviance. If you accept that change or that non-standard practice, that workaround in this area, then it becomes more acceptable to accept that in other areas too. This is well studied. So if you're okay with that, then you're okay with not giving an antihypertensive within the defined time frame, or ignoring severe hypertension, or not giving MAG because you don't believe in it, or whatever it may be. It creeps and creeps and creeps, and leadership, they lose trust.
I'll tell you oh, go ahead, Julie.
I think, sorry to interrupt. I think that what I have seen happen too is when the workaround is a shortcut, and that shortcut is not a full, it might not be a full assessment, it might not be full standard of care, but nothing happens. And that creep you're talking about, Stephanie, is deadly, because if nothing ever happens and you didn't do what you were supposed to do, like count the respiratory rate, and that creep just continues, when you find yourself in a patient that is not going to tolerate that lack of assessment or that lack of clear looking at what's going on with that patient, then all of a sudden, when something bad happens, you look at how far you are from the standard of care. It's like, how did we get here?
So, Julie, you don't know this because you're not on social media. And I am. So,
Yeah.
just this week, a nurse posted on social media that she was shocked that in a discussion at the nurse's station, she was shocked that not everybody listens to patients' breath sounds. And that they don't do a full head-to-toe assessment on their patient because they're low risk, or because they don't have time, or they look at their patient and say, well, she's low risk and she's not having any difficulty breathing, so I'm not going to worry about it unless, their pulse ox drops, or, she starts complaining of shortness of breath or something like that. So she was shocked. And a lot of the comments on there, I think people were shocked too. And they were like, I do a head to toe assessment on every patient at least once a shift, which is standard. And most hospitals say, you have to do this. You can't not do this, right? This is the standard for our hospital or whatever. And that is fairly standard, but I think that's a great example. You start doing that for one patient and you stop doing it. But I guess what this is maybe is the not can do attitude, because we talked last podcast about having staffing standards in your one-on-one and active labor with those patients. And we're asking for that. And then you get it. And then you're not going to listen to their breath sounds because
you don't have time.
You don't have time. Yeah. Like, what are you doing? Or another social media example, it was like, have you ever seen a contraction that looks like this? And everybody said, oh yeah, that's what happens when the patient is like pressing, like tightening our abdominal muscles and making uterine contractions. They're like, what do you do about that? It was like, you go to the bedside and you palpate.
Uterus.
You do not nurse from the nurse's station, guys. You cannot assess uterine activity from the nurse's station. And if you are, then you are not nursing. Yeah. You are not providing standard of care. And that is making me crazy these days. Yeah. But that's the non-can-do attitude, I guess. So,
well, one thing that just astounded me is I've heard now from 2 different hospitals, well, the maternal early warning criteria don't work. And I'm like, what do you mean they don't work? They're criteria. Well, the system doesn't let us know when the patient has them. And I'm like, you're counting on your system to tell you? I'm like, this is not a system notification. This is an assessment.
And the system notification is the backup.
Yes.
It's the backup for when it's not recognized. It's not the primary. You don't need, I mean, it helps you so you don't need to remember all of this stuff in your brain because there might be multiple things in your, but you should know abnormal vital signs, and the system is the backup for when you haven't checked vital signs in a period of time, or you missed it, or what, and the MA didn't tell you. I don't know, but yeah, you can't rely on that solely.
I was speechless. I was literally speechless. I'm like, okay, help me understand what you're saying.
Well, it's not like you have 100 things to memorize either, on that list. It's not like these are like norms.
Well, and like, it's not just about like equipment and other kind of workarounds. It's also about staffing workarounds. So like, for example, let's just talk about the charge nurse. Okay.
Gosh.
Like the charge nurse, you guys know more about this than me, but it's my understanding that they shouldn't be having patients. They are running the unit. They should be supervising and leading and running the unit. But very often they will maintain an active role in the patient care scenario because there's inadequate staffing, or they have a primary role in an emergency, which means if another emergency happens, where's the leader of the unit and what's happening to the unit while this unit leader is actively managing the emergency instead of stabilizing, assigning roles, whatever, and moving on to the next responsibility, or doing direct patient care or admitting patients or discharging patients. Like those are not, then when are they doing a charge nurse responsibility?
Yeah. Or being the second nurse at the delivery and only staying until, certain time period or whatever. They're not really fulfilling that second role of the nurse. They're just showing up to check. We had 2 nurses here at the delivery, but who has the role of the newborn, who has the role of the mom is not being assigned because they're stretched too thin because they don't have enough staff.
And they're making it work.
Yeah, yeah. And I think, on the leadership side, there's going to be days like that, right? There are going to be shifts like that again, because you do not have even your on-call nurses in there, or you flexed up or whatever. You're still going to have scenarios that are like that. But if it's the norm, that's when it becomes an issue that you're not meeting the standards that you need for your patients. And that's when leadership needs to listen. And they should have that data that says this percentage of time we're not meeting that criteria that we aspire to have. But and also I think it depends on the size of the unit. Like if there's you're only staffing 2 nurses, like we've been in hospitals where they may do 40 or 50 deliveries a month. They may not even have a charge nurse, right? They may have just divide and conquer. They have a major can-do attitude. I applaud those nurses because
I do too.
I've never worked in that size of a hospital, so I can't imagine. I mean, because if they don't have a labor patient, they're off taking care of men in the med surg unit, or in the emergency department, or they don't even get to come in and work. So, but when it hits the unit, that charge nurse may be required to take care of patients, but they are not also having to direct traffic for 14 other rooms. And in those units, the 14 other rooms, besides the 2 that you have active patients in, you are the air traffic controller as the charge nurse. You can't have a lead role in the emergency, which would have stunk for me as having done charge nurse role for many, many years. I wanted to be in the emergency. So I'd have rather been in the emergency than as the charge nurse, right? But that charge nurse is so essential they're the only one that knows what's going on in the OR. They're the only one that knows forward flow of patients. They're the only one that really knows what's going on every patient on the unit. And you've got a ton of rooms. you can't be tied up.
I think that it's really hard when the charge nurse, and the charge nurse shouldn't take a patient assignment. But I think for a lot of people in maybe administration, I'm not sure, but when they see that there's a nurse there that doesn't have a patient assignment, it's like, well, let's just do that and let's give them this and then we can give them that, and they take on more and more and more responsibility. And I've worked in enough high acuity settings where I guarantee you, if someone's going to have a severe hemorrhage, somebody else is going to code, or they're going to have a seizure, or something's going to happen. You have to have that person at the nurse's station running that unit. It everything goes amok when you don't have a leader. And your analogy of the air traffic controller is perfect. Okay, let's pull the air traffic controller and let's have them go, I don't know, do
Fly
a simulation or something, fly the plane.
Land the planes.
Yeah, go land the plane or go out and direct traffic. And then what happens with all the rest of the planes?
Yeah, well, and then what happens, and we've all been there, we all know this, we so don't want it to impact our patients and our other team members, that we all, like, especially in a time of crisis, you've had a staff exodus, you've had, a volume increase that's unexpected, or a perfect storm of multiple things happening, right? And then you have everybody picking up the slack because we don't know what else to do, right? We don't say no, we just make it happen because we may feel if we don't, our job is at risk. We don't know what else to do except to say yes and just work our butts off and then go home and lick our wounds, for the next 12 hours and then go back and do it again. And then the reward is, you guys are so awesome at making this work. This is our new standard. This is how it's going to be from now on, because congratulations, you've demonstrated that it's possible to do it.
Mm-hmm. Yep.
So good job. Keep it up.
Yep. Yeah. And we'll keep getting you pizza for lunch.
Yeah, pizza that you don't have time to eat.
And poor night shift never gets pizza. Night shift never gets pizza.
Well, and in the physician world, I can speak to my world, the maternal fetal medicine world, a not unusual scenario is, I'll just take the outpatient setting. Okay, you're in the office and an ultrasonographer is gone. She's either out sick or quit or injured or whatever. Okay. And now we've got a room full of, like, an MFM typically runs multiple ultrasound rooms, not one room. Okay. And then we're seeing patients in addition to those ultrasound rooms that are happening, and we read all the scans and see the patients. That's a pretty typical scenario. But it's not unusual. I mentor a lot of MFMs and I interact with a lot of MFMs. And one of the things that I teach them and talk to them about is, you're not an ultrasonographer. So we might be skilled in it, we might be trained in it, but stepping in to replace a sonographer because they are out, because we do not want to reschedule or cancel patients, does not solve the problem. It makes everything worse. And we need to feel empowered to say, I am not an ultrasonographer. Just as a nurse, you can't do, I'm the charge nurse. I'm not taking an assignment. I'm not the admission nurse. I'm not the discharge nurse. I can't cover triage. Like, it's okay, a one-off emergency, all right, but it very easily becomes this is the way we do it here. And this is the way we do it here becomes common.
Yeah.
And then anytime someone calls off, one of us is just filling the gap, and it's not our role.
Do you remember, I remember one meeting that I was in, and somebody said, well, we haven't killed anybody yet.
I've been in meetings like that.
And I said, is that
our standard?
Is that our goal, is just to not kill someone, or, oh my gosh, it's like, that's not a high reliability organization. That's not a patient safety plan, is to just not kill someone.
Well, one of the ways I describe risk to patients, when they're like, well, am I high risk? I'm like, it's not a badge of honor. Okay. But I'll explain to them there's degrees of risk, right? And so the more you do these kind of creep things and lack of boundaries and clear roles and responsibilities and all that kind of stuff, it's the way I think of it is, it's like driving on the freeway without a seatbelt. and you're just going faster and faster and faster without a seatbelt, you're probably going to be fine, but then you might die.
Yeah.
Or be harmed permanently,
Yeah.
right? You can't predict when the accident is going to happen or when the issue is going to happen, but the faster you're going, the longer you're doing it, and without a seatbelt, the greater the likelihood something's going to happen. If you're doing it once a week for 30 minutes, that's lower risk than if you're doing it all day, every day at 90 miles an hour.
Well, and this is where leadership and risk management play a huge role. Again, if this is turned into your norm, number one, leaders don't have a job without staff. Okay. That's who they're leading.
But I think I think they feel, I don't know, but I think there's situations where the leaders' jobs get protected, but the staff don't. So they feel vulnerable, right? That, even though they are leading us, I still feel vulnerable that I'm replaceable.
Yeah, true. That can be. But it's still, that's their job, is to lead
Yeah.
the unit. And so that, number one, have to know what's going on the unit. They have to be responsive to what is going on the unit. And again, if it's a consistent issue that you don't have enough staff, or you don't have good forward flow of patients, that is backing everything up. It's delaying everything. It's delaying the OR. It's affecting anesthesia. It's affecting the physicians. And number one, it's affecting the patient care. Then you have to be responsive to that. And again, not a one-off, but a consistent basis. That is your responsibility to address it.
I've been in institutions where they just pile stuff onto the leaders, the unit
Yes,
management. Oh my God.
they do.
And I had another thought too. I think there's really, I know we all feel this anxiety about people going through training and then just not practicing medicine or leaving their nursing job and selling real estate, whatever it is. And sometimes I wonder if this creep that we have allowed, that really it impacts your work life. It impacts everything. And people that are young come in and look at this as like, no, I'm not going to live my life that way, and we lose them. So
Yeah.
I don't know.
Well, I can tell you a scenario I was in where I burned out big time for many, many reasons. But the nail in the coffin for that experience for me was a situation where I was in a position of leadership, but not power. Okay. And there's a difference.
Yeah.
Right. So I had the title and I had lots of responsibility and lots of expectations, but no actual power. Okay. And I was in a really untenable situation, but I was kind of blind to it for a long time, just loving being a doctor, loving working, loving the team I was with, just loving medicine. Like, I love being a doctor. I love taking care of patients until you can't do it anymore, right? And I think this is what you're talking about. This is the hidden part of it. So I was in a scenario where a patient was trying real hard to code. She was hemorrhaging internally, post-cesarean. We were in the PACU. I was in the process of resuscitating her, I was at the bedside, for a long time, dealing with all the things that need to be dealt with. I was by myself, no learners. So meaning no extenders. Okay. No residents, no students, no fellows, no nurse practitioners, no PAs, no nobody, just me. Okay. Didn't even have a surgical assist. And I'm trying to manage this patient. I've got probably 35 or 40 patients still to round on in the hospital. Ultrasounds to read, plus, and that's just the known work, not the people in labor who need attention and the whatever may walk into triage and the phone calls that are happening and the Vocera or the pager or whatever exploding every 5 seconds, right? That was just the known work. And I'm calling for help. I recognize I'm in over my head and I need help. I've got a safety issue. Please, someone come help me. There was no hospitalist. There was nobody. I had to call and find help. And I was told no over and over and over. Not because no one was willing, no one was allowed. No, you may not cancel patients and go to the hospital. No, you may not leave that responsibility and go to the hospital and help Stephanie. And so I saved the patient's life. I somehow got through my day, and I decided to put my leadership hat on. And I went to my leadership and my leaders' leaders, and I said, this is not safe. This has to change. And the response that I got was, oh my gosh, oh, absolutely. We hear you. We know, we agree. So you just, in your free time, write a proposal to hire another physician that will demonstrate how it will make us a profit, and we'd be more than happy to help you. I quit my job. I had no choice. Yeah. I didn't quit that day. That was the beginning of the end of me saying, I can no longer say yes to everything. Something bad is going to happen that is not going to be able to be fixed. And I can't sleep at night with that. I couldn't fix it. And so I had no choice but to leave it. But that's where that make it happen, make it work, can do attitude will bury you and your patients if you're not careful.
Yeah, I think there's a huge issue right now. Well, not just right now, but it's been brewing up to this of nurses feeling the burnout. They know the staffing standards of A1, that is the goal, but they're never meeting it. And they're feeling unsafe. I mean, because let's be real. When I went back into staffing not that many years ago, it was shocking at some of the requirements that nurses have to do, and to document on that are not even relative to the patient care that they're providing.
Do you mean like a Braden skin score?
Yeah. Braden's, yeah. Now I'm gonna start talking about skin assessments now, and or fall risk, or suicide assessments every 4 hours or whatever. I mean, come on, really? Or can they feed themselves? Well, they're not letting them eat, so I don't think that's really essential right now. But or they, oh my gosh, I mean, just the admission process that is required on Epic, for instance. I mean, come on, get real. Half of the stuff is not relative, but we're being told you have to do it. And then my all favorite is you can't leave the shift until you get your care plan done, meet those nursing, goals or whatever they're called. I can't even remember. I mean, I guess the nursing goals that you have that are meaningless. But instead, we need to have something, interprofessional. But okay, that's another topic. But it's that kind of stuff that we're just spending our time to where you don't feel like you have adequate time to do the real things that are meaningful.
Yeah.
And when you can't do the real things that are meaningful, like support the patient, like do your assessments on time and actually have time to document them, or you had an emergency and you had to stay after to document, it's a real burnout. It's a real turnoff. And for newer nurses, especially, that causes a lot of anxiety because they're still trying to figure out if their comfort level. I mean, because it takes at least a good year for a new labor delivery nurse to feel confident in your scenarios that you may have come up, because we may have OB emergencies, we may have, fetal heart rate changes, so on and so forth. And if you're understaffed, and if you don't feel like you have the resources, and if you don't have the systems, it can lead to burnout and they're quitting. And it is a very expensive process to orient a new nurse to obstetrics. And if they leave 6 months after they've been oriented, you've just spent thousands and thousands and thousands of dollars getting that nurse oriented, and then they quit.
Well, and I kind of a tangent that fits here is, when you're in fight or flight all the time, like you're in the unit and labor and delivery is can be chaotic and unpredictable. I think people think everything is unpredictable and we have more emergencies than we need. And sometimes we're creating our own emergencies.
Yes.
But if you are getting bombarded by pages and calls and you have to be everything to everyone all the time, that is going to contribute to this. Where's my meaning? What's the lack of meaning? And I mean, meaning is what keeps us doing what we're doing and putting up with some of the crazy things in healthcare. But Julie, I want to talk about emergency response in that, because I think one of the most common things that we see is everybody is responding to everything every time because they want to support their team member. They want to make sure that that one emergency situation is handled appropriately, but it adds to the stress and the burnout and this, your nervous system constantly on edge all the time because everybody's responding to everything every time.
Yeah.
And you have now depleted the entire unit of everybody to go take care of that one situation. And I guarantee everybody, in most units, you don't need every person, okay? You're the rural facility with 2 nurses on staff. Yeah, you need every person, okay? But we're talking about the majority here. So it's just overkill most of the time.
I've seen it so many times. And in so many hospitals, everybody just comes running, and not even just from labor and delivery. God forbid you have a maternal cardiac arrest. You'll have half the hospital there. And
but not on time.
Well, and they all come in they stagger. And it's just so disruptive to have too many people in the room who don't know what their role is. And it was just such an eye-opener for me to watch really efficient trauma teams, because you don't come in the room if you don't have an express purpose in that room. And I think we need to really take a lesson from them. We aren't going to practice exactly the way they practice because they have a different patient population. And one thing I've learned in simulation, particularly because I worked so much with neonatal teams, they simulate very differently than OB teams because they have different structure. They have different practices. They practice neonatal resuscitation a lot. Well, our resuscitation could be a whole range of things. It may be a shoulder dystocia, it may be an arrest, and the problem is, if you don't know what you need to handle the emergency and you don't know how to anticipate the emergency, then you're always going to have too many people coming to the room. You're always going to be caught at the 11th hour trying to figure out what to do for this patient, when we all know if you would use appropriate maternal early warning criteria, the vast majority of the time, you're going to know who is going to have an emergency. So you can prepare for an emergency.
Yeah, that's so true. I mean, because very rarely, like on the soap operas, as it happens, I used to watch soap operas. Oh, yeah. Well, they're sitting up in bed. They look beautiful. Their makeup's great. And their pillows, they have too many pillows.
Lots of pillows.
Lots of pillows, like they're occluding their airway because they're like this. But anyway, they all of a sudden they're like, and I flatline. It doesn't happen, right? Doesn't happen. I mean, very rarely. What you have PE, an MI, I guess, which
maybe an AFE, maybe a stroke.
Maybe a stroke. Those would be the only things in OB that we would see that would be like snap, flat, code. But that's why you don't see flash pulmonary edema. You go back and you review the chart, and they've been having, if you found the respiratory rate has been increasing, their pulse ox has been decreasing. They've been changing their mentation. They've been having all these warning signs, but very rarely is it something that's just so acute onset, I guess the only other thing would be acute onset fetal compromise. We're pretty good
But even
at that.
then, much of the time, you can't prevent a cord prolapse. You can't predict a cord prolapse. You can't. But we just see it so much where we assume that nothing
Mhm.
is predictable or preventable, and we're in constant reaction mode. And when we don't have clearly assigned roles and responsibilities for these emergencies, even if they are not planned for and whatnot, but if you don't have roles and responsibilities, then you have charge nurses taking in primary roles and depleting the unit, to everybody else leaving their pit patients and their whatever to come flood the room and make it noisy and chaotic and loud, and 3 people doing the same work and the essential work not getting done because nobody knows what they're doing. We're all just running around. And I mean, another thing I say all the time, just because you work really hard, are really busy, and care a lot doesn't mean you provided good care. That's not, I mean, good bedside manner does not mean good care.
Well, and that can-do attitude of, "We can do this, and we
Yes.
can handle our own, emergency." And I see that a lot of times back in the OR, because ORs in general, like the main OR, they handle their own emergencies.
Mm.
And they see a lot more, uh, compromise and code situations in the OR. They think we've got our anesthesiologist, we have everybody here that we need, and they usually are well supplied. But we may or may not have that scenario in obstetrics. We may not have our refrigerated medications back there, may not be the meds we need for a code situation, so on and so forth. But we have that attitude of, we can handle it. We got this.
And I
And
think the more you pile on to people,
yeah,
the less they get to the things that, I mean, a basic assessment is important. Counting respiratory rate for a full minute with your stethoscope when you've got a high risk patient, it takes time. And it's not one of those, it doesn't seem to me to be one of those things that people get applauded for. So you begin to not do those basic things because you're got these other responsibilities or these other things you're supposed to be doing. I see it all the time in when I'm training maternal arrest teams. It's like, oh, we've got to get an art line in, but you're not doing good chest compressions. The art line ain't going to do you any good if you're not doing good chest compressions. So I think sometimes we stray from the basic because we've got too many other things going on that are distracting us. And it is, by definition, basic.
Mm-hmm.
true.
Yeah, it is
And
true.
it burns out. You burn out because you don't feel like you're doing a good job. You can't meet the needs of the patient. You burn out, or you go looking for something else that maybe is easier, because over time it affects your attitude about going to work. It affects how you feel about working an extra shift, because you know when you go in there what it's going to be like, because it is just crazy. And you know that if they call you
Yeah.
on an off day to see if you'll work, you know what you're walking into.
Yeah.
Yeah.
You're walking
it's
into
awful.
combat, right?
Yeah.
Or you have a
Yeah.
bad outcome,
Yeah.
or a near miss, and then it's kind of one of two situations. You're in denial about what could have been done better, and you think everything was done right because everybody's hair was on fire,
Mm-hmm.
or you realize this was just a matter of time and you can't deal with this anymore, and you either
Yeah.
leave your job or you leave medicine because you feel so out of control about the whole situation. We have more control than we realize.
Yeah.
It's not going to be fixed in a day. It's not, and you do have to have leadership support, but bedside teams are everything, and you do have more influence than you think, especially if you are, banded together as a team, not just to plug all the holes, but also to try and influence change and fixing some of the things.
Yeah. And I want to give two possibilities that I think can make that change, okay? The first is an interprofessional group that meets regularly,
Mm-hmm.
that determines how you're going to care for patients on your unit. And that can be hard for physicians to take that extra time, um, to not see patients in the clinic, to be on the unit, to participate in that. So how that looks is going to be different for each facility. But it's a great opportunity to involve hospitalists, for example, in those processes, that because they're there, the nurses are there, they're both being paid by the hospital to do a specific work, get together and have that regular committee that writes the protocols, that determines how that care is going to be provided, the resources that you need, and that can speak up to the current issues on the unit so that you can start to solve them.
Yes.
Leadership can't do that by themselves. Nurses can't do it by themselves, and physicians can't do it by themselves. And everybody becomes angry and burned out if you don't address the issues. And the safety problem still remains, okay? And then the second idea is that nurses should have unit boards. You should have shared decision-making within your own unit. And you are employees of the hospital, and the hospital is responsible for the care that you provide. And you want to say so in how that's done, right? So it's another opportunity and another way for your voice to be heard, but that requires you to participate and do that. And again, finding that time and finding that resource of when you're going to do that will all vary, but that is very important. And I'd much rather see nurses utilized in that way than sent home on low census days too, that they could be working on redeveloping or solving an issue that's for the unit and getting those resources that you need. And you have more power, like I said, than what you sometimes think.
Thanks. Great. Really good suggestions.
Yeah.
Practical,
Yeah.
Well, they don't have to be complex either, It doesn't have to be a complex, but it's so important. And I think that, when I've done that with nursing teams, I've literally had nurses say, we've never done this before. No one's ever listened to us before. They've asked us to do a dilation station bulletin board. Well, I got news for you. That dilation station bulletin board does not have anything to do with how you care for your patient.
Yeah.
It doesn't have anything to do with anything except for making that board have something on it. And it doesn't address clinical care issues. And I'd much rather see nurses utilized in that manner than to develop a dilation station bulletin board.
On that note.
Well, we just saw one, so
they're all going to go back to their unit and look at their bulletin boards and go, holy cow. Like a lot of time goes into those, and that's time that could be spent doing other things potentially. So
yes.
Yeah.
Yes. I mean, do chart audits. Has anybody ever done a chart audit and you go, holy cow, it really changes your own practice when you do a chart audit to see if you're meeting the protocol or meeting the clinical guidelines that you have defined for your own unit. That's going to be a real popular statement. But it's true, you'll learn.
Well, I think that's a good point to wrap it up. So hopefully this has been insightful for you guys, and you've got our perspective, and maybe you share it, maybe you don't. We'd love to hear what you guys have experienced with, the can-do attitude and the can-do culture in your own units, the positives, the negatives, the questions. Share it with us.
The questionable.
The questionable. Thanks for listening. Don't forget about the Critical Care OB Academy at clinicalconceptsinob.com, and help support our mission by joining us on Patreon at patreon.com/CCOB. You can watch us on YouTube and find us on all the social media channels. Thanks, everybody.
See ya.
Thank you.